Hello, Cardiology Update, readers, viewers, and listeners. My name is Chadi Alraies, cardiologist at Detroit Medical Center in Detroit, Michigan, United States. I'm coming to you with other review related to one of the most important and very important topics, common interventional and general cardiology as well. In this episode, we're going to talk about recent publication at Cardiology Journal, speaking about one important topic related to bleeding post-TAVR. As we know, TAVR is a very common procedure now, and it has surpassed the number of patients undergoing surgical aortic valve replacement in the last 1 to 2 years. However, medic bleeding that happens after TAVR continue to be a major problem. It's not major a problem in terms of bleeding and transfusion, but also has an impact on patient mortality post-procedure. As we are enrolling more patients in low and intermediate risk, this bleeding risk has been trending down. However, we don't know really what is the trends and the incidence and predictors of bleeding in this population. Therefore, this article and study in specifically has been looked into this pattern, incidence, trends, as well as predictors of bleeding post-TAVR. So let's dive deep into this article. The article itself looked into a large database between a year of 2007 to 2022. Large database, a lot of thousands of patients that involved in the TAVR. This is a single arm, meaning they're only looking into the incidence, temporal trends, as well as the predictors of patient undergoing TAVR, with no comparison to surgical population. The mean age was in the 81 years, which is older population. So that speaks into the fact that we still have majority of the patient involved in this procedure are older population. And as we go forward, we get this, I think, number going to go down as we are enrolling more low and intermediate risk TAVR in these procedures. Surprisingly, in a positive way, 56% of the population were women. This is, I think, for me, one of the positive points where I see women very comparable to men and also more than men in one registry. So looking into the predictors as well as the incidence of bleeding, major bleeding, which is defined bleeding requiring transfusion or requiring drop in hemoglobin more than 3 grams, has been 6.6% in the total population, and minor bleeding is 4.6%. However, the trends of the bleeding, major bleeding, has been 11% and coming down all the way to 4.6% over the course of the study. Also noted is this major bleeding and minor bleeding has consequences and adverse event on the patient. Let's start with the minor bleeding first. There was no mortality associated with patient had minor bleeding. This is defined as a small hematoma or a bleeding that was managed without transfusion. However, on the other hand, major bleeding has a major impact on patient outcome, especially in the first 30 days post-procedure, as well as beyond 30 days. There was an associated mortality with this population who undergoing TAVR procedure and have major bleeding. There was also association between, in terms of predictors and what are the risk factor for bleeding, between the patient hemoglobin before the procedure. The lower it is, the more risk for bleeding, major bleed. 2 is peripheral vascular disease. 3, women also has more tendency to have bleeding compared to men. And one of the major risk factor and predictor for bleeding was frailty. As we know, frailty has not been studied very well, and as this is not because of lack of literature, but because of not good adjudicated frailty score that can speak to these patients' frailty before going for the procedure. However, there's multiple efforts done before looking into the albumin level, the functional capacity, the patient functional capacity, as well as other comorbidity like COPD, home oxygen, and so forth. But one way they adjudicated, as well as when they did sensitivity analysis, frailty continued to be the most predictor for bleeding, major bleeding post-TAVR. So how we can fill this gap? Again, the authors did a wonderful job in illustrating this risk factor, but they really pointed out that there is a lack of literature and as well as studies to evaluate the frailty before the TAVR and what tool we should use and which one is the best one. I think, and in summary, this is a wonderful article. I really enjoyed reading it, and I will highly encourage everybody. We're going to put the link for the article at the bottom of this video as well as in the description. It's a wonderful article. I highly encourage any structural heart as well as interventional cardiology to take a look at it. I don't think there is any major changes with the practice that we do now, but however, I will encourage the operator that evaluating the frailty is very important. That's number one. Two, in order not to avoid patient going into the frailty phase, I think early referral of these patients to the structural heart clinic is very important. This is when the patient is still functional, has no COPD or no oxygen, or patient is still independent in his or her activities on daily living. I think it's very important to capture this patient early on. So I think early detection is important. Early referral to structural heart disease clinic is very important. Again, meticulous access techniques, as we all know and has been practiced a lot and has been advocated for, is using ultrasound guided access as well as using closure devices with the closure devices that the operator are comfortable with at the end of the procedure. There is also some discussion about how we can utilize a single access in terms of minimizing two arterial access for the structural heart, as we know routinely. And if there is a future, we're going to be able to do this procedure transradial. Again, I really enjoyed this article. I'll encourage most of you to, all of you to take a look at it, especially if you're practicing structural heart intervention in general, especially TAVR, and also watch the videos and others on Cardiology Update. Thank you again for listening to us. This is Chadi Alraies from Detroit Medical Center, and this is Cardiology Update.